Okay, so good afternoon, everyone. It's a pleasure to be able to be here despite not being in person. So thank you for everyone who invited me to present today. So I titled my presentation Growing Amidst War, Children and Youth, Mental Health in Armed Conflicts. And we will be discussing an overview of what it means to be a child in armed conflicts and the massive impact that it has on children's mental health. As it was mentioned just before, there's a disproportionate impact of war on children. They are often the primary victims of our conflict because they're very vulnerable. However, I do want to mention that these children are made vulnerable because their parents and the people that are meant to protect them are also under harm. And I find it very important to mention, as I'm just coming out of Gaza 2 weeks ago, after almost a year there, and definitely the mothers and the fathers, the men being under disproportionate attack as well, making their children even more at risk. And the founder of Save the Children said every war is a war against children, which I think is definitely true. So in 2024, UNICEF said this was one of the worst years in its history for children in conflict. There are now 1 in 5 children that is affected or living in war zones globally. And although children make for 30% of the global population, they make for 40% of the refugee population and almost half of the internationally displaced people. So showing how vulnerable they are. And there are more than 52 million children that are estimated to be out of school at the moment, knowing that school is one of the most protective factor in terms of development, in terms of routine and what children needs. And when faced with armed conflict, children are very frequently deprived of their most basic needs, whether water, shelter, food, psychologically supportive environments, opportunity for schooling, whether educational or even vocational, resources that promote positive psychosocial development and mental health. So having access to playgrounds, to safe spaces, to green spaces, and also physical health. When in a war zones, the threat to the body is always present. And so this comes in marked contrast with the need of children to develop in safe, secure environments. And the infliction of war and military aggression on children comes as a violation of their basic human rights, whether it's right to life, to health, to non-discrimination, equity. And of course, it has very long-term consequences for the development potential. Not some will do well, of course, but depending on the level of impact, if we look at Sudan, Gaza right now, this will bring very, very long-term consequences. And when we look at the effects of war on children, there's a huge variety of signs and symptoms that we can see in children. So we could see specific fears, fear of noises after hearing a lot of bombings, or the sound of the drone. It could be fear of specific people. We see a lot of dependent behaviors and regression. A lot of children that were had toilet training suddenly stop being able to do it on their own. Then prolonged crying, we see it a lot. The lack of interest in their environment and the psychosomatic symptoms is very, very common. So we have a lot of children coming to us with different type of pain and complaints. A lot of aggressive behaviors, so increasing, of course, when you're surrounded by violence. And this goes into the play as well, because children do repeat what they see, trying to make something out of it, trying to process what they are seeing, sometimes as a sign of trauma as well. And we see a lot of impact also on sleep, on eating, and toilet training. So these are things we can see. However, the most important thing to consider when working in war zones with children is that the most common disorder is actually normal reaction. if you're a 5-year-old and you are under constant bombardments, and especially at night, so you cannot sleep. And so you're not able to concentrate anymore. You cry a lot. You stop trusting the world around you. All of these would be completely normal reactions. And so I really want to emphasize this because sometimes we feel very helpless in front of the population we serve, but even more in front of children, because there's something in them that touches us even more. And we may be too quick at diagnosing, of looking for diagnosis. But the most important thing is to contextualize. Yes, some children will have acute stress reactions, will have panic disorders, anxiety, depression, PTSD. And PTSD, I really want to mention here that we can only talk about PTSD if the conflict is has stopped. Too often we will talk about PTSD when it's ongoing, it's protracted. If we think of Gaza, of Sudan, of Yemen, of Colombia, you have ongoing conflicts over decades. And yes, you can have symptoms of PTSD, but the PTSD concept is a Western concept. It's a good one, but we need to think of it differently when we work in ongoing armed conflicts. And although prevalence surveys will show very high levels of depression, of PTSD, it is impossible when filling a survey or doing data collection to distinguish between normal stress reactions versus persistent clinical mental health disorders. So this is really our role as clinicians, whether you're a doctor, whether you're even a social worker, HP, like it's really our role to know the difference, and to contextualize, to remember what the children are facing every day. Because the risk is to individualize a suffering that is collective and to also sometimes depoliticize a suffering that is created by political violence. So, an example from Gaza, this was a survey made by War Child in June 2024. And it shows devastating results, saying that 96% of children felt like that death was imminent. 92% of children did not accept reality. And the most scary is that one children over two, so 49% of children wish to die because of the war. This is one children on two. So if we look at these data, we're like, oh, wow, children in Gaza have a lot of anxiety, have a lot of depression. But if results are so high in the whole population, the issue is not with the children, but with the context that is pathological. It's not to say that we cannot offer support and care to these children. It's to say that we need to make sure we don't label children that are just having normal fear, normal sadness, normal grief when there's such like circles of grief that they are facing every day. The most protective factor, at least one of the most protective factor, is definitely relationships. And I really want to emphasize this because this is where often we do have some control. We don't always have control, of course, on the political conflict, but we have control on or we can try to support the caregivers, whether they are the parents or extended family. And we know that the capacity to adapt and thrive in front of adversity really, really is supported by the presence of at least one supportive relationship. It does increase coping skills and it strengthens the ability to face adversity. And family and community acceptance makes a very big difference. So one example I want to give here is when I was in South Sudan in 2021, I was in Abyei, so close to Agok, and there was a mother, she was about 22 years old. She had been abducted by some soldiers at the border with Sudan. And she suffered protracted sexual violence over a couple of years. She was married to one of the officer forcibly, and she gave birth to a baby. When I saw her for the first time, she was with a 2-year-old. The mother was clearly very. She has a lot of signs of trauma, of depression, of anxiety, and the baby the whole time was not moving. He would just ask for breastfeeding, and he would be completely kind of frozen. And so the mother comes for herself, but I see there's a baby involved, and the baby is clearly affected because that 2-year-old, they also have a mental health. And so we supported the mother. And one thing we did is asking, okay, because she was very stigmatized in the community. And one thing we did is we contacted an aunt that she had in a village nearby, and the aunt accepted to take her. And so she was taken by the aunt, and the woman living around her aunt started like taking her to the field to work with them. And as she was coming back, the baby started laughing in the session with us. He started interacting with us. He started playing. Their relationship uh, became better as well. So this, by supporting the mother, you're supporting the child, and this makes a whole difference on the mental health of that mother, but directly the mental health of this baby. So this is why the socio-ecological framework is very important because the child is at the center of it and its whole development, all aspects of development. But when we support the child, we need to support his family, the caregivers, and also the community. Some of you may have access to community leaders or to teachers. So maybe one of the treatment would be to actually support the teachers in building their skills and basic psychosocial support or emotional support in times of war. So when children go to school, they can include in there. Even we did this somewhere in Congo, so to discuss with the teachers so that they would give some skills to the children or discuss it with children in school. And we're doing a bit of prevention at the same time. And for those who are humanitarian affairs officers or advocacy managers, maybe you can even influence or try to give some substance to how we share with ministries of health or on the political level to try to enable to support environments that enable more well-being for children. And so when we look at all this, we need to look at the risk factors and the protective factors and really include everything around the child, which also includes the culture and the social political environment. There are many resources. We won't go in details through them because I think they will be shared with you later. But here, the IAS guidelines for MHPSS are extremely important. They are our foundation in all the work we do in MSF, WHO, everywhere, and also the MHPSS MSP that I will present just a few things about them. So what I want to show about the IAS guidelines here, this is our pyramid of interventions for all the services we offer across the world within all the programs in MSF and elsewhere. So the numbers are reversed, but the first layer is basic services and security. And this is where food, shelter, water are part of mental health. This is how we how can we offer these services in a way that ensures dignity and protects human rights in the way that food is distributed, for example, and in a way that is socially appropriate. The second layer of services that we offer is community and family supports. So how do we support community grassroots organizations that are already working and supporting women or supporting men or children? And how do we support this so that we increase the well-being of children and their communities? And this is also where we can discuss child-friendly spaces for children to have safe spaces to be even within war zones. And then we have the focused non-specialized support. This is where we can offer counseling, for example, or GP can also learn the basics of MHCAP and do some counseling with patients. And we will finally have the specialized services, psychologists, psychiatrists, and mental health team per se. So it's really important to have this level, this multi-level approach because we're really tackling MHPSS mental health at all levels for children here. Because most children will need level 1 and 2, and they will never need level 3 and 4. And some children will need level 3 and 4, but the more we focus on level 1 and 2, the more we prevent. Then I want to discuss the importance of a multi-sectoral approach, and this is from the MHPSS MSP, multi-sector minimum service package. And I won't go in details now, but I really, really suggest you have a look because this is where it explains everything on how to implement MHPSS services for children, for their caregivers, for teachers even, It gives a lot of resources, and it really speaks to the importance of working intersection sectorally. So for one service, for example, I remember in Congo, there was a place where water was distributed, and there was a little PHCC behind just beside the wash station. And so people would come for water, but at the same time, if they had mental health issue or questions for their children, they knew that they could come to the PHCC without being stigmatized because they could have access to water at the same time as a medical question or MHPSS question. So really trying to work together to increase the access to mental health services and decrease stigma as we do it. So a few quick things here. We want to step away from focusing on trauma only to normalizing stress responses that are normal in a context that is abnormal. Contexts are creating pathology when we're underwater. This is abnormal for children to be under bombs. When we stop focusing on trauma and focusing also on how resilient and capable children and teenagers are, we see them as active agents of their own healing or their own life, which is very important. And instead of just referring all the time when we are faced with children with mental health issues, it's how can we empower caregivers and teachers and community leaders in supporting children. The scalable psychological intervention, this is something developed by WHO, but a way to train non-specialized mental health professionals in offering psychological care for children. So this is something that can be very useful for teenagers. For example, we have the EASE program that you may, I think the resource might be shared with you as well. And really focus on improving diversity in our services and the working across sectors. I want to finish on the importance of contextualizing on cultural adaptation, because no matter how good our guidelines are and no matter our experience, if we do not contextualize and really adapt to the needs and the cultural needs of where we are, our interventions may not be accepted, they may not be useful, and they may not be sustainable. Because even if we work in emergencies, when we leave, people stay. And the more we increase cultural adaptation, the better. So I will finish on a little word on liberation psychology that was developed in South America and Latin America during times of political repression. And it kind of turns away from the traditional Western psychology, focus on the individual to really center collective experience, historical context, and social justice. So it contextualizes trauma and situates it within systems of oppression. It also asks us as clinicians to look at our own positionality and where we are from. How do we play into the system of oppression? If we want to really support children that are living under war and under oppression, we need to include this in our understanding and in the way we intervene so that we regain them a sense of power and give them the power to have their own narrative and to tell us their story. So, as a conclusion, James Baldwin, who was a Black American writer, said, "I never have been in despair about the world. I've been enraged by it. I don't think I've been in despair. I can't afford despair. I cannot tell my nephew, my nieces. You cannot tell children there's no hope." So, thank you for this. And I'll see you later in the panel discussion.